Hello Team Phoenix and welcome to my YouTube channel. This is your girl Catherine Maina. Please call me Kate Mimi. We will be talking about dialysis today, so shall we get down to it? Thank you. Phoenix, I hope you've subscribed to this channel because it's a very good channel, believe me. We don't just speak about healthcare workers and their issues, we also look at our health and we discuss different non-communicable diseases. My goal actually when I started this channel was to take medical conditions and discuss them in a simple language. So far we've been dealing with chronic kidney disease. I know there are different forms of kidney disease and I will talk about that as we go on, but I want to zero in on something we call dialysis. Now remember, when we have been talking about chronic kidney disease, we said that one of the ways that we treat this disease is actually kidney transplantation. Now, please remember that we do not have enough kidneys in the world. Even first world countries do not have enough kidneys to go around for the number of people that are contracting chronic kidney disease on a daily basis. So what happens is that we have different methods of sustaining life, and one of these methods is actually dialysis. Now, dialysis is a broad term, and most of you might know dialysis based on what you've read in books, what you've seen on movies, and probably having seen a machine at the hospital. I want you to understand that dialysis is actually of two forms. We have hemodialysis and peritoneal dialysis. Whenever you hear a word hemo in medicine, it actually means blood. Whenever you hear hemo, it means blood. So hemodialysis, blood dialysis. In simple terms, dialysis is cleaning blood. So hemodialysis, cleaning blood, but this time we are using a machine. We use an external machine whereby we get blood from the patient's bloodstream through a very large vein. We call it a fistula or a graft for that matter. I will explain all these many things as time goes by. So we get blood, we put it on a machine through an artificial kidney, which is called a dialyzer, and then it is cleaned and returned to the patient. Now, our regular kidneys, our native kidneys work 24 hours, 7 days a week. They never go on break. So that means that whatever we are doing and whenever we are doing it, our kidneys are always cleaning the blood, isn't it? Now, when somebody's kidneys have failed and they have to undergo dialysis, we're actually shortchanging them because they will be doing dialysis on different days of the week. We call it intermittent dialysis. So it means that this person at any point in their lives or during the week, they will be having accumulation of all those things that we say they are supposed to be removed by the kidneys. Think about toxins, think about waste products of metabolism, think about excess water. All these things will be retained in the patient's blood because they have to wait until they go and do dialysis. And even then, regularly people take dialysis for between 3 and 4 hours, unless it is depending on one's blood results. I know in Kenya, at least what I know is that it is 4 hours every twice a week. Now this is quite dangerous, I have to say so, because if indeed our system is working 24 hours, 7 days a week, what is happening for 5 days that this dialysis patient is not receiving dialysis? What is happening to their body? What is happening is they are retaining too much salts, they are retaining too much water, they are retaining too much waste products, and these things are what causes complications when a patient is undergoing dialysis. And one of the common complications is actually a heart attack, which we call a cardiac arrest, and also fluid in the lungs. So in other countries like the United Kingdom, they do dialysis at least every 3 days in a week, which is fair. You know, it is fair because the patient will have at least 4 days where they will not be having dialysis, and these days are spread out. For example, somebody dies on a Monday, Wednesday, and a Friday. The other person is a Tuesday, Saturday, Tuesday, Thursday, and a Saturday. It becomes spread out. The other form of dialysis is what we call peritoneal dialysis. Now, this one is rather complicated. See, our internal organs in the abdomen, they are covered by one layer of a double sheet called a peritoneum. Say that again. Our internal organs in the abdomen are all encircled, protected by a sheet of membrane, but it is double fold. It is called a peritoneum. Now, this peritoneum becomes a darling when you're talking about peritoneal dialysis, because what happens is that in this double, remember I've said it is a double shield, it is a double sheet membrane. It means that we can easily have a layer inside, right? Think of a sheet that is like this. So inside we have inside it we have a layer, okay? Whether we appreciate it or not, we do have a layer, and that layer becomes very important when we're talking about peritoneal dialysis, because what happens is that inside that layer we have a very good supply of blood to the other organs of the body. I mean to the abdominal organs in the body. We call them visceral organs. Now, that layer can be used for dialysis. What happens is that surgeons make a wee hole on the abdomen, just near the navel or the belly button, depending on what you call it, wherever you are, and then they go inside that layer, of course guided by a computer. They go inside that layer and they insert a catheter. A catheter is just a wee tube, okay? So they put in a wee tube, and then we can put in a fluid that we can help the body to do the process of removing waste products from your body. Now, this layer is such that one side is covering the outer part of the abdomen and the other side is covering the internal organs. This side that is covering the internal organs has a lot of blood supply. So that is what we are banking on as renal nurses or the renal team. We are banking on the fact that the peritoneum has a very rich blood supply mechanism. So when we put in that fluid in there, it's called a dialysis, okay? Remember, we are talking about peritoneal dialysis, which is the process, and then dialysis, which is the fluid that we are going to use for us to be able to remove the waste products. So when we put in that fluid inside the abdomen, what is going to happen is that the process of removing the toxins will happen slowly over maybe over 6 or 8 hours. Remember, in hemodialysis, we were talking about 4 hours or 3 hours or 5 hours, or if you're in France, 6 hours. I know of a center in France that does 6 hours dialysis, but then again, that depends on the specific research that has been conducted. So with peritoneal dialysis, it is like having a native kidney. Ladies and gentlemen, you're having a native kidney. Why? Because this fluid is removing all the toxins in your blood, and it is giving you, because we can easily add other substances to this dialysate. For example, if you're having low calcium, we can look for a dialysate that has a higher concentration of calcium. That means calcium can flow from the dialysate to your blood, and the toxins that are there can flow from the blood to the dialysate. Can you see that process? That is what happens. I really hope I'm making sense. The process is called ultrafiltration, convection, and all those other lovely things. But because we speak later in this channel, all that we need to know is that there are substances inside the dialysate fluid that are going to go into the bloodstream. Why? Because we said there is a very rich supply of blood in the peritoneum, okay? After that happens for about 6 to 8 hours, what you do is just go and open that catheter. You know, it looks like it has a wee tap. You go and open, you drain the fluid, okay? And then you take another fluid and you put in. So that is what happens. The only disadvantage probably is a distended abdomen, because some people look like they have a, you know, like you always have a beer belly, or some people will say, oh, I'm getting fat on my tummy, but then again it is some fluid that you have, because it is about 2 to 3 liters of fluid that your peritoneum is going to hold. So those are the two different types of dialysis. You might want to ask me, why don't we do peritoneal dialysis more often, especially in Kenya, where we have very limited machines? Part of the reason is because of the costs involved to buy that fluid. The one that I've told you is called a dialysate. Part of that reason. The other reason is a fear, which could be justified or not, about infection, because it is so easy, if you're not doing proper hand hygiene, it is so easy for you to get infected in that peritoneum, and it is quite nasty. It is a serious infection when we have an infection in the peritoneum. Now, ladies and gentlemen, the other thing you need to learn is that dialysis today has become a patient initiative more than nurse initiative or a healthcare provider initiative. So that means that people are increasingly wanting to take control of their own dialysis treatment. So I don't know where you're watching me from, but I want to believe that you have come across people wanting to do treatment in their own houses. So what is happening today is that people are having machines installed in their homes. I am aware of a few Kenyans who have machines in their houses and a water treatment system, and they just do dialysis in the house. Whether it is a hemodialysis, whereby we are using that machine, or we are just using the manual dialysis, whereby it is a peritoneal dialysis, patients are increasingly wanting to take control of their own treatment. And you know what? That for me is a win, because I believe that the time for patronizing people is over. The time for patronizing our patients is actually over. I believe that we do not just tell people what to do, we discuss. And if you're in a position to take control of your own treatment, then go ahead and do it. We only need to empower you. We only need to let you know what is supposed to be done, where it's supposed to be done, how it's supposed to be done, and you carry on. If you're able to insert your own needles in your fistula or your graft, why not? I mean, we need to teach you, because these things, after all, it is you living with the disease. It is you who understands you best, and not me as a nurse, not the other person as a doctor. So it is quite important. So we have covered the two forms of dialysis. I want you to understand other things as we go along. There is something that you will have to undergo every time that you're on dialysis, and that is we will need to take some blood every month and check what your biochemistry levels are. Now, hear me out. These two processes, especially hemodialysis, let's talk about hemodialysis for a moment. The word is hemo, so blood. It is a blood-intensive procedure. So anytime we are putting those needles, or maybe using the catheter, which is just a tube connected to the heart and tunneled under the skin, allowing us access to your bloodstream. Anytime we are using those two methods of accessing your bloodstream, we are losing some blood. All the time we are losing some blood. The other thing is, whenever that machine, the blood is going through the external, the external machine, that is the external kidney, which is an artificial kidney, and through the machine, we are losing some blood. And also the red blood cells are being crushed. So you are at a very high risk to develop something called anemia. Well, now, that is on top of the kidneys failing to provide erythropoietin. Remember, when we were talking about the functions of the kidneys, ladies and gentlemen, I told you that one of the functions of the kidneys is actually to provide a hormone called erythropoietin, which is used in the manufacture of red blood cells. But when the kidneys have failed, we are no longer producing erythropoietin. So, coupled with all these other factors, you really are going to have anemia. And anemia is just low blood count in your body. You're going to be very tired. Even if you undergo dialysis how many times and we are not sorting your anemia, we are actually making the situation worse. So you will be needing two items. You will be needing, not necessarily two, but these two are the main ones that you will require. You will require iron supplementation. Do I say iron or iron? Iron. What am I supposed to say? Is it iron or iron? Okay, fine. I'll go with iron. You need iron supplementation. Is it iron? Okay, fine. Iron. You need iron supplementation, and you also need erythropoietin. So we need to give you these two drugs. Now, what happens when you're undergoing hemodialysis? It's so easy, because we can always give it to you through the machine, and we don't have to keep on pricking you all the time, all right? So that is the wonderful thing that you're going to do. At least 6 months, or is it once a year, we're going to check your vitamin B12 levels, and we're also going to check your folate levels. These things will guide us, because vitamin B12 and folate, iron, and erythropoietin, all these things are needed in the process of blood formation, okay? That is what I'm going to call it. It is quite another very intense process there. But the thing is, you need vitamin B12, you need folate, you need iron, and you need erythropoietin. So and also intrinsic factor, of course. So when you have all these things, your red blood cells are going to be formed, but the rate at which vitamin B12 and folate get depleted is not as fast as the rate that iron gets depleted. So we are really going to look for iron, and we're going to give it to you. If you're going to have peritoneal dialysis, you will end up getting an injection of iron, either through, most likely it is through your vein. We're going to run an infusion to give you iron. And how do we do this? At least every 3 months, we check your iron stores, because it takes about that much time for the iron stores to build up. We end up checking, and then every month we are going to check your hemoglobin level. Your hemoglobin level is what is going to guide us. It will tell us, do we need to reduce the dose of erythropoietin, or do we need to increase it? Because the problem in dialysis is that if your hemoglobin goes beyond a certain level, now you're going to have problems of clotting on the machine. You will start losing blood. You know, like we have started running the blood through the machine, and then boom, it just clots. It's because your blood becomes too viscous, that is too thick. The other thing is that it can cause clots even in your bloodstream. It is usually a very tricky balance when a patient is on dialysis, making sure that they are not anemic, that is the hemoglobin is not too low, and they are not having too high hemoglobin, which is going to cause problems. So that is what happens, ladies and gentlemen. The other thing that we're going to look at is something called bone and mineral disorders, because when we talk about dialysis, when you talk about kidney disease, another function that I told you of the kidneys is actually the metabolism of vitamin D, and also the reabsorption of calcium and excretion of phosphate. These are some minerals that we need in our body, although we need them at particular range. If we have too little calcium, we're going to have brittle bones. If you're going to have too much calcium in our body, we are going to form casts. Casts are like small nodules, accumulation of calcium salts in our bones. They are going to be deposited, and it's going to be very painful, and it can also easily cause a fracture. Okay, so our kidneys, what they do at this particular point, besides synthesizing or metabolizing or activating, actually the word is activating. I don't know why I'm using so much English. The word is activating. Besides activating vitamin D, what our kidneys do is that they excrete phosphate, and they help in reabsorption of calcium. Now listen, when we are having kidney failure, we end up retaining a lot of phosphate in our body. Phosphate is not too great, because it is going also to form those bone casts. Why am I saying casts? Gosh, it's supposed to be casts. So high phosphate in the blood is not right when somebody has kidney failure and they are on dialysis. So you will find that most of the time, because we get phosphate from almost all foods, especially dairy. Whenever you think about milk, you think about butter, you think about cheese, you think about chocolate. All those things bread, okay? All those things contain a lot of phosphate. So what happens is that the doctor is going to prescribe a medication that is going to bind, okay, hold together the phosphate in that particular meal, such that instead of it being directed to the kidneys, which have already failed, it is going to be directed to the intestines, and then you can eliminate it through the other process, okay, not just the kidneys. So that is what happens. So you want to be careful that your phosphate levels are within the correct range. If they are high, your doctor will most certainly prescribe a medication to bind those phosphate. So make sure that happens. The other thing is, we talked about activation of vitamin D. So you will need an active form of vitamin D. Now this is different, because for me, when my kidneys are working the way they are working, I can easily get my vitamin D from meals, because we say that fatty meals contain vitamin D. And also the sun is going to give me vitamin D, but it is going to be activated by my kidneys. But if your kidneys have failed, it means that even if you're getting adequate sunlight, even if you're getting adequate meals which contain vitamin D, it is not being activated. Does it make sense, people? It is not being activated. And what good is a vitamin if it is not being activated? My point exactly. So what will happen is that we are going to give you active metabolites of vitamin D, such that your body is going to be ready to absorb that vitamin D without necessarily having to take it to the kidneys, because the kidneys have already failed. I really hope this makes sense. So those are some of the medications that people are going to use. Now, as I come to a finish, I will want to appeal to everybody who is out there, and especially because of my patients back home and the renal community back home. These medications are very expensive for people in Kenya. For you in the United Kingdom, you might not appreciate this because you have the National Health Service and everything is free for you. If you're in Germany, the same thing. I know medication can be free there. It is very expensive in Kenya, because patients sometimes have to make a choice. Do I buy medication to bind my phosphates, or do I buy foods? That is the decision that people have to balance all the time, and it makes me worried, because they end up with bone disease all the time. So somebody starts dialysis when they are walking straight, they are fine, but give them 2 years, they are on a wheelchair. Give them 2 years, they are not unable to walk completely. These are the things that I want you to realize. If there is a way you can help somebody buy phosphate binders, if they have been prescribed for by the doctor, please help them. If somebody is on dialysis, please remember it is not just about NHIF, which is health insurance in Kenya, which really helps pay for the dialysis sessions. I want you to realize all the other costs that are involved in dialysis. Please help somebody. Buy for them something, even if it is the active metabolites of vitamin D. Just find out what has been prescribed by their doctor. And you insurances out there, you including NHIF, you need to come up with a way to cover for these other extra costs. It is not just dialysis. It is not just about putting patient on a machine and helping them clean their blood. It is about all these other supplements. We need them to be okay. It is not enough just to connect them on the machine, because that is as much as circulating blood and also adding problems on top of a bad situation. We need them to achieve quality of life. We want them, even if they are not going to get kidney transplantation anytime soon, we want their life to be at an optimum level. We want this person to be able to go back to work and continue the excellent business of building Kenya. So help somebody, insurance companies, come on board and pay for these medications, because it is the right thing to do. And if those medications are not available in the hospital where dialysis is happening, NHIF, please have a scheme where you're going to tell patients they can go to any pharmacy, present the NHIF card and get the medication, because it is as simple as that. That is the only way that you're going to help them. So that's it for today. I'll talk more about peritoneal dialysis next time. I have only touched about it. And if you have questions, feel free to talk to me, ask, and then guess what? Subscribe to this YouTube channel, because we are talking amazing things. Thank you very much, people. So until next time,